Welcome to ArtBreak, the lecture series dedicated to seeing art through a different lens. Each session features a speaker who gives insight into their worldview by sharing their interpretation of works of art at the CMA. Today's topic of discussion is Design by Time, a poetic exhibition featuring cutting-edge international designers exploring how objects can embody the element of time. We now welcome Dr. Anjali Joseph, Professor and Director for the Center for Health Facilities Design and Testing and the Smart State Endowed Chair in Architecture and Health Design and Research at Clemson University. If you are joining us live, please insert questions for Dr. Joseph in the Facebook chat during the talk, and stick around after for a live Q&A. And now, Dr. Anjali Joseph.
Good evening. Welcome to this presentation on architecture and the choreography of healthcare. This is being presented as part of the Design by Time exhibit from the Columbia Museum of Art. And it is an opportunity for me to reflect about the relationship between design and time from the perspective of a researcher and an architect. So I thank the Columbia Museum of Art for inviting me to be a part of this discussion. To tell you the truth, when I was invited by Wilson Bain to talk about this, I was very intrigued because the audience that I usually present to are healthcare designers or architects and often clinicians who are interested in designing or building healthcare facilities. But thinking about designing and in the context of time and how time impacts people's interaction with space, that's a very central tenet to everything that I do. So thinking about how this exhibit, the Design by Time exhibit, fits within this field of architecture and healthcare was quite an interesting journey for me, just in the context of this presentation. So I look forward to sharing some of the work we do here at Clemson University, and hope you enjoy and can provide your own perspective on some of these. So the Design by Time exhibit is rather a unique exhibit that has brought together artists from around the world that look at the interaction between space and time, and showing how time can be embedded and represented in different kinds of materials or in terms of space. And this is one of the quotes from the exhibit. Space by itself and time by itself are doomed to fade away into mere shadows, and only a kind of union of the two will preserve an independent reality. I thought that was very profound. And what I want to add to this is, in the conversation, is the human being. That is a very central element of all the work we do in architecture. Architecture is meant to be used, and architecture is never neutral. It impacts people as well as how people impact space. So as human beings, we see ourselves as being sort of the controller of our spaces and of our environments. We change things. We make things the way we want it to be, but very rarely do we realize that as we make changes to the environment, the space itself changes us. And that change happens slowly over time. So my presentation today is going to be along those lines, and in that way it will connect with and reflect upon the exhibit by time. Design by Time exhibit. So environment and healthcare, that is the context of the work I do. This is a very famous quote that you very frequently see when you have architects or others speak about architecture and try to make the case that architecture really makes a difference and it impacts people. So this is a quote by Winston Churchill: "We shape our buildings, and afterwards our buildings shape us." And he made this sort of comment in the context of the debate for redesigning the Commons Chamber after it was destroyed in the Blitz during the Second World War. And he made the case that it was very important to preserve the rectangular shape of this Commons Chamber in order to maintain sort of the adversarial setup that was there originally, which helped to maintain the relationship between the two-party system and parliamentary democracy. He felt that was important for those conversations to happen. And I think at some level, we all, we feel we control our environments, but our environments also control us. And architecture in some ways is so solid. It is so long lasting. It lasts for centuries. I come from India, and I used to live in New Delhi, where there's remnants of buildings and architecture from centuries, one built on top of the other, and it is so permanent. And it's amazing to see how people don't even notice sort of the old history and the architecture, and they use it in so many ways as a as a place to get together with your friends or your lover, or just to go for a walk. But it is this permanence of architecture is impacted by where it's at, the location, how we perceive that architecture. Even though it is so permanent, it changes over time, and not only because of the context, like in this one, that it's viewed, where the time and the space and the people in the environment change how it's perceived, but it's also that point in time. How a particular building is perceived in the 18th century may be very different from how it's perceived now, within the organizational and the cultural context of the time. We ourselves know how many changes have taken place in just the last few months, and our perception of our environments, our monuments, our buildings, our cities, our campuses has all changed. Just within the scope of say 100 years, we what was appropriate and was good is no longer the same. So spaces change just in terms of not just in terms of how they are, but also in the context of the environment and the culture that they reside in. And this particular building, why do I have this here? This is something that's very close to my heart. I started studying architecture in India, and one of the buildings that we were, or the spaces we were supposed to analyze as part of a history class, was St. Mark's Square in Venice. And I was fascinated by how that space was designed and how that plaza was designed, and the beauty of the buildings, and the vistas when you walk through it. And I had the opportunity to experience it myself last summer when we went abroad with a bunch of students to look at different places in Italy. So it's exciting. What I realized when I was there is that it's not just the buildings that are so beautiful, but it is the experience of the space and how people appropriate it and use it and experience it at different points in the day and over a period of time. So for me, this relationship between space and time, and in the field that I work in, it comes to life when you consider the people. When people inhabit it, they change it, they make it their own, and that happens every single day, all the time. And this is a question for you, for those of you who are on Facebook Live. Leave a comment. Tell me about your experiences. Have you thought about how cities and buildings and rooms change you? Um, or do you assume that you're the one making those changes? Do you work differently? Do you, for example, work your workspaces? How have you had to make changes to your home environment so that you can work from home, or that your kids can work and go to school virtually while you're in the room next door? Have you had to make some major changes to make that happen? And so, see, these changes sometimes happen very gradually over decades. Sometimes it's a daytime and an evening time thing. You reconfigure your space from morning to evening. Sometimes it's minute to minute. And it's understanding how humans need to make those changes and how the environment supports those changes. That's where the magic lies. So the field that I work in is environment and behavior, and it's a subfield within the field of architecture. And what we do is we study the interactions between people and the environment, and it's based on sort of the understanding that we as people, we impact our environments. We change it every day in terms of how we use the spaces, how we build buildings, what materials we use, how we use energy, and so on. But also the environment impacts us. And it is these dynamic interactions that occur over time that impact both the environment and the person. So it's a dynamic thing. We're changing each other constantly all the time. Um, one of the earliest studies in the field of healthcare design, which is a sort of a subfield within environment and behavior, was a study by Dr. Roger Ulrich. So in 1984, he did the study where he looked at data uh, from patients who had been seen in a hospital in Texas, where they had been assigned to rooms either with a view of nature, So from these patient rooms, they could look out and see a grove of trees, or they had a view of a brick wall. So these post-surgery patients, what he found was that the patients that were in rooms with views of nature used less medication, anti-anxiety medications, and they perceived less pain, and they recovered faster and went home faster after their surgery. So this was kind of a breakthrough. It was published in Nature magazine, in Science, and it showed for the first time, I think, in empirical terms, something that we all knew sort of intuitively, that views of nature and exposure to nature make a difference. That if you design spaces where you can bring nature in, either through artwork or through views or being able to interact with nature, it can actually make a difference and can impact people's health and safety and well-being. And I see that even in the Design by Time exhibit, there are a lot of exhibits, and a lot of artists have taken inspiration from nature, and using that to in their artwork in many different ways. So the challenge that I have as an architect and a researcher is understanding this relationship between space and humans over time. These things cannot be separated from each other. It's a dynamic and ever-changing thing. So as a researcher, my challenge is how do we study these complex systems? And it's not just human beings. Human beings are interacting with technology. They're interacting with other humans, they're interacting with the space, they're interacting with policies. How do we look at all of that in a holistic way? And how do we make sense of that research to inform decision making? And then how can we design how can we make designs that will allow these dynamic changes to happen? Because one of the things is that architecture is permanent. Once you build a building, it'll last for 50 years. That's true for hospitals, but everything else changes. The way care is provided changes, the technologies, the care protocols. Something dramatic can happen, like a COVID-19, and suddenly you have to think about how you lay out your spaces in a hospital to ensure that the staff is safe, the patients are safe. So how can you build these buildings so that they can work on a regular, normal schedule and normal challenges, as well as heavy duty or unexpected challenges such as COVID-19. So this is one of the models that we use quite frequently in our work within my center. Is this model, which is a systems engineering model? It's outside of architecture, but what it does is it begins to think about the system as this complex, interacting and dynamic set of components, which includes the organization and the policies and the culture, the tools and technologies that are needed to provide care. The people, the person is always in the center, because they interact with all of these elements. The tasks that people do, everybody has a specific role in healthcare. You may be a nurse, you're a patient, you're a family member, you're a doctor, you're a care provider of respiratory therapist, and then you work in different kinds of environments. So they all interact and they change all the time, and that impacts processes as well as different kinds of outcomes, like pain medication use, medication errors, or a patient fall in the hospital. And then that the system hopefully learns from how this is how all these elements work, and it's constantly adapting and improving. So that is the whole time element, the adaptation piece of it. So this kind of provides the foundation for some of the work that we do at Clemson in the Center for Health Facilities Design and Testing. The Center for Health Facilities Design and Testing is located within the Architecture and Health program at Clemson. So I'm not sure how many of you know, but Clemson has a dedicated program in Architecture and Health. And our primary goal is to teach students of architecture how to design safer and better quality healthcare facilities. So we have graduate students and master's students and PhD students who are focused on different aspects of healthcare. And these are all the faculty that work in this program. David Allison is the director of this program, and he's been here for 31 years, I believe. So what do we do at this Center for Health Facilities Design and Testing? Again, within the context of what I mentioned earlier, the goal is to do rigorous and replicable research that can make an impact in South Carolina as well as outside of South Carolina, in the nation and in the world, and to create a national research laboratory, a testing laboratory. The idea is that we understand human relationships in healthcare, and we come up with design concepts that are innovative, and we can take those risks within the context of our center. And there is a perpetual cycle of doing the research, coming up with design concepts, and then building it and prototyping. That is something pretty unique about our center. We build these very much like some of the exhibits that you see in the Design by Time exhibit, and then we test them, and then we're constantly improving the cycle of research. And our focus is on those settings in healthcare where the greatest risk is there, where most vulnerable patients are seen and where treatment is delivered. And we look at patient safety, patient and staff experience, as well as population health. So these are the kind of things that we study at our center. We look at how design impacts operational efficiency and clinical effectiveness. How can we do more and better with fewer resources? How can we be efficient? How can we be safer for our patients and for our staff members? How can we protect them? How can we improve the healthcare experience? Because at the end of the day, we are all patients, and we are users of the healthcare system in some form or the other. And I found that most of my students are extremely passionate about this field because they have experienced healthcare in some form or the other, either themselves or through their family members, and they know that this work can make a difference. So I'm going to share a couple of projects with you. And the purpose of sharing these projects is to show again how that interaction happens between space or design over time and human beings, and how we actually go ahead and study these complex environments, and how that is then translated into actual design, and how do we know whether these designs work. So just a couple of examples to share with you on that. So this is how if you look at an architecture magazine or some of those award-winning projects, and this is an operating room, and this is how you would imagine it to be. It's complex. It has all these equipment. It has lots of devices. It's very, but it looks very beautiful in some ways. It looks like it's very efficient. It is a picture of efficiency. But the reality is that this is often how work is done. There is a big gap between how we imagine that people work in the space and how they actually work in that space. And that's where a lot of the conflicts happen between this work is done and work is imagined. And our goal and our work really is to understand this work is done from the ground up, so that the architecture can then support people over the course of the day, over the course of many, many years. So this project that I'm going to talk about has been sort of what we've been breathing at the center and living for the last 5 years. It's funded by the Agency for Healthcare Research and Quality, and we started this project in 2015, and now we are pretty much done. We are wrapping it up. At this point, it's a collaboration between Clemson University and the Medical University of South Carolina. And what we've done is, over the course of these years, started off with literature reviews and case studies. We've spent a lot of time understanding what happens in the OR, that work is imagined, what's really going on there. And the teams that have been looking at it are very interdisciplinary. Our team includes architects, industrial engineers, operations researchers, nurses, anesthesiologists, and surgeons. And no one person or discipline has a full picture. We look at it from our own way, and we know parts of it, and we are experts in designing parts of it, but we need that interaction and the collaboration with all these different elements of these different disciplines to make sense of this problem and to come up with a solution. So that's what we did in the first year. In the second year, we designed some concepts around operating rooms, and we tested it frequently. We had 6 rounds of testing, and eventually the design was implemented at 2 surgery centers at MUSC in Charleston, and then we went in to evaluate it and see if it worked. So this is just some of the things that we did, and I added this slide in just to show you sort of the variety of methods that we use in our field to study sort of human behavior and interaction with space over time. One of the main things we did was do video observations of surgery. So we video recorded 35 surgeries with cameras in 4 corners of the room, so that at every point in the surgery, every second, we knew what was going on and what people were doing and who they were interacting with. So these little spaghetti diagrams that you see shows how the nurse is moving around in the operating room over the course of the surgery. And then we also did another study where we looked at how people arrange themselves around the patient during the surgery to understand how that changes over time. So this is a little bit more about the video observation because we've used it quite a bit in our study. So we had 4 cameras, we audio recorded it, and so we could see what was happening at different points in the surgery. And so we recorded 35 surgeries in 4 different ORs. And what you see here is the organization of the operating room into different zones or spaces. And these are functional zones. So the red zone is where the nurse works. This is the surgical workstation. This gray zone is where people walk around. This is the surgical table where the patient is operated, and there are spaces around it. So the idea with this is to be able to know where people are at any point in time, and which space are they occupying and what are they interacting with and who are they interacting with. So again, going back to that whole design by time, it's important to know how people are in space at different and how they're using the space in order to be able to design by time and support create a space that actually supports work over a period of time. So we looked at where disruptions were happening, how often doors were being opened, lights were being turned and off, on and off. All these things are important because it deals with how people flow through the space and how they interact with each other. Because a surgery is a very deeply coordinated activity, we need different team members to come together at the right time, with the right instruments, with the right information, and the right patient for the surgery to be successful. So that requires a lot of coordination behind the scenes and right in time for the things to work properly. So that's what we were studying here. And so these were the ORs that we looked at. And this is just an example of a study where after we did all those observations, we had a good sense of how people flowed through the space. And using that knowledge of where people work and how they move in the space, we began to test certain ideas. For example, if we had the bed at different angles in the room, how does that impact where people move around in the space? If the room is smaller or larger, and that has a huge impact on cost as well as efficiency. We looked at increasing the size of the room by a certain amount to see how it impacted where people move. So these are the different kind of uses of that data that we collected. So anyway, after about a year and a half of problem analysis, we moved to the point where we could begin to design the space. So we started with coming up with design objectives. So what are our goals? You heard some of the goals that we had earlier, but with the operating room, the goals were to improve efficiency, optimize experience, enable the ability to change over time. And so these design goals helped us to determine where we were going with the project. So we had 8 students in the architecture and health program. These were graduate students. They came up with an early design concept, and you can see we came up with the concept, and then we took up some space in Charleston at the cigar factory, and we put tape on the floor. And we brought in some random, boxes to represent different surgical equipment, and we had the nurses and clinicians actually come in and walk through the space, and they were testing out how would that space actually feel if they were there doing the kind of tasks that they would do at different points in the process. But this was a very rough space. It didn't really have walls or anything. So in the next phase, then we built cardboard walls around the space, and we again ran a bunch of different simulations where they simulated a pediatric surgery and orthopedic surgery. And the people you see here are actual clinicians who then gave us feedback on what worked and what didn't work. So this improved in terms of fidelity of that design and the fidelity of the mock-up. Eventually, we built high fidelity mock-up of the operating room, which looks very similar to an actual operating room. And then we had different clinicians come in and do a lot more in-depth simulations to see what worked and what didn't work. So this is what the final design of the operating room is, and this is a very different audience from the ones that I'm usually talking to. And you may or may not be interested in what this OR looks like, but just in brief, we were trying to, based on our behavior, the observations that we saw. We realized that it was very important to create clearly defined zones in the OR, so a clear place to say where the bed would be, where would the anesthesiologist zone be, so that their work was not interrupted by others moving around. So the anesthesiologist is usually in the one corner of the room. All the traffic happens in the lower corner of the room, so that it doesn't interrupt the surgery where the instruments are located and so on. We also suggested having a window in the operating room. You'd be amazed at how many operating rooms, in fact, most operating rooms in the United States don't have windows. And if you're a nurse or a doctor working in these spaces, you could spend days and days without any daylight. And the research shows that daylight and views to nature are extremely beneficial for everybody, especially those who work in these kind of high stress environments. So this is what the final operating room looks like, and this is our simulated patient. We call him Bob. He was here at Charleston until about a month ago, and unfortunately, we've taken down this mock-up. It doesn't exist anymore, but we still have that as a 3D model that you can see on our website. So once we build this high fidelity mockup, we continue to do this testing to see how do people actually work in the space. Can we simulate the activities as if it were a real OR, and what can we learn from that? Can we continue to make changes? So we did 2 rounds of simulations for pediatric and orthopedic surgeries, and these were the goals. We not only, you saw the goals we put together to design the space. Now we had to go in and see did it really work. So at this point, I wanted to quickly show you an example of one of the simulations that we have that we've run, just so that you get a sense, because it's a little abstract until you can actually see what it looks like. So this is the mock-up that I was telling you about, so you can get a glimpse of that. And this is a pediatric surgery. So this is a little baby going in for ENT, ear, nose, throat surgery. And the patient is being prepared outside in an induction room. So the induction is happening there. And you can see all the coordination that needs to happen. So the nurses are coming in, they're setting up the room just right. The screens are being placed so that the right setup is in place. And now they're going to be moving the patient into the operating room. And all the folks that you see around who are standing there taking notes, that's my research team. We are observing how people are moving in, what paths they are using. Are there any challenges as they bring patients in, as they turn the bed? Are there bumps or twists anywhere? So you can see how the anesthesiologist coming, setting up the patient, and getting them ready for surgery. They're moving them from the gurney to the surgical table, a real surgical table for the baby. And then the physician is getting ready. They're moving the bed out of the way. You can see all the different things that are going on there with the patient. So this is almost very realistic. It's like a real surgery because they could do a lot of the things, including the lights. They had the right instruments. But the simulation that we did right in the beginning, those are very simple simulations. We couldn't get to this level of detail. It was just tape on the floor. We had objects. If they came in, came out, but that was okay for the kind of design questions we had at that point in time. So this is almost like they're running a full surgery. But this allows the clinicians to really see how that space would work and what the specific challenges might be. Sorry about that. Yeah, so as I was mentioning, you saw the research team members who were standing at the corner taking notes. So there were 5 team members who were each observing the movement of one individual, and you can see these little scribbles that show the path of movement of the different people. We're tracking the different phases of the surgery. Any surgery can usually be broken up into a preoperative phase where you're preparing the patient, intraoperative when you make the incision, and postoperative when the patient is coming back out of induction and being ready to then go into a unit to recover. Again, that whole aspect of time is really important because the space itself, even though the walls don't change, the entire space is being reconfigured pretty significantly during these different times in the process. So we were studying how that was happening and what challenges were there, especially during the intraoperative phase. So you can see these were the paths of movement. We studied each individually and then we brought them all together. So we not only were we looking at where they were moving, you can see where the bed position is changing, instruments are being brought in. There's a lot of dynamic changes happening over time. We're also seeing with those little red dots where there were any problems, where somebody was bumping into something, or they didn't have enough space, or there was interaction happening between different people. So that finally we ended up with our prototype and the physical mock-up. And so through the course of this 4-5 year project, we've learned a lot of things. We've done a lot of research on different aspects of OR design. We've tested it. We've developed methods and tools to study this complex system. And then the goal was to then put it together in a way that designers and clinicians can use it, because research is often published in peer-reviewed journals, and it isn't very accessible to the lay public or even to the informed clinician or the architect. So we put together this Safeword design tool, which has these key elements of the different aspects of the operating room. How would you design the storage? How would you design the anesthesia zone? What are the key considerations for designing windows or doors? Each of these elements has significant elements, significant features that need to be considered, and decisions that have to be made. So this is how we set it up. And each of the design strategies is linked to a rationale, which tells you why you should do that, as well as some of the outcomes associated with your decisions. So this is just this begins to show you how different design strategies are linked to different kinds of outcomes, and which of these systems components they begin to impact. So this is the link to the actual tool, and I can show that to you very quickly. So this is what the Safeword design tool looks like. And the way it's organized is that you can go into any of these things, say the circulation zone, that's the area where you would find the nurse. It'll tell you these are the different kinds of strategies that you should consider. Provide sufficient circulation area to accommodate the flow of all the different people. And then it tells you why should you do that. And then it also has links to different citations. Where does this information come from? Because it's important, especially in the healthcare world, that these design decisions are actually based on evidence. Then So as I mentioned, after that, much of the work that we completed was implemented at the new surgery center in North Charleston. And this is a view of the operating room that was designed. I think I have enough time to very quickly show you another study which uses some of the similar methodology, but it's a very different environment and a different way of studying.
Here's what I found.
Oops. Sorry about that. In this study, this is part of a project that was actually implemented at the Children's Healthcare of Atlanta. They are in the process of designing a 400-bed children's hospital, and as part of that process, they have conducted a whole bunch of the simulations. You saw what we did for the operating room, but they've run these simulations in 3 different rounds for all kinds of spaces: intensive care units, patient rooms, operating rooms, patient units, all the possible sort of high-risk patient care spaces that you could think of. And the reason why they did that was to understand how the spaces are used, because for clinicians, if as an architect I come to them and I show them a plan of the space and say this is how things are going to be, it's very hard for them to visualize what a plan looks like, and what does it mean to me? How am I going to be in that space? How am I going to use that space? So they did this huge project where they converted a whole warehouse into a sort of a mini hospital, where they built out all these little rooms, and they brought teams in to do these simulations and provide feedback. That work then led to a slightly improved design, and we came in at sort of, I think, point number 3, where they've done the third iteration of this process. And we looked at the videos that they created for the pediatric intensive care unit, and we analyzed 3 different scenarios that that they conducted. So one scenario was where a patient is a pediatric patient, so a child coming into the pediatric intensive care unit in respiratory failure, and they're being taken care of. In the second scenario, the patient gets a little more serious and they have to be intubated. And in the third scenario, it's the same patient requiring an ECMO cannulation, which is an even more complex procedure requiring surgeons to come into the room and conduct some surgical procedures. So what I'm trying to show here, not so much the details of what we found, but more the methodology and how we're studying this and how that interaction happens between space and time. So you can't see the details here at all, but what you'll see here is these 3 different scenarios and some of the critical changes that are happening over the time that this scenario is being enacted out. And during this time, the people are moving, they're occupying different spaces in the room, new equipment is being brought in, and some significant things are going on that impact patient safety. What is standard or what is fixed is the space. So the design or the walls don't change, but everything else within that is changing. And if the walls are not designed properly, all these changes can be fairly harmful to the patient. So in this particular scenario, as I mentioned, the patient is admitted in respiratory failure. So they may be coming in from a different unit or coming in from the emergency department. And this shows you sort of, you can see the clocks, how that's such an important part of everything. So when you design a space, you're not designing it for it to be frozen in time, but for it to support activities over the course of years and days and minutes. So you see how before the patient is brought in, the nurses are coming in, they're setting up the room in certain ways so that the patient can be cared for. They bring in the crib and they transfer the patient in there, and the scenario goes on. So as architects and researchers, how do we analyze the space? I think that is as much as I would like to share. In the Design by Time exhibit, you've seen different ways in which people have embedded time in their art or used time or rhythms of time. How are they embedding that in something else like a piece of material or weaving? In our case, what we try to do is look at people's behavior in space and time and then figure out how to visualize that. And that's pretty complex because there's lots of different things going on. So this is just a graphic that shows you who are the people. So we have the pink is the respiratory therapist, the yellow is the nurses, and then the patient is not even in the room right now. But we've organized this room into different zones so we can understand how it's being used. And these little graphics here shows you the problems we've identified. The little dots are lack of space, or there's an equipment conflict. We're also tracking where these different zones are, who are the people involved at that point, what equipment is needed, and what sort of problems are being encountered. So we're trying to, and you can see the little timeline at the bottom. We're trying to see how this evolves over time. What are the changes that are happening over time, and how would you design the space so that it can accommodate changes irrespective of time and activity that is needed. So again, this is evolving. You see more things happening with intubation. Suddenly, the size of the circles increases. That means the number of disruptions is increasing, and the color of the disruption shows how significant is the disruption. Is it something that's fairly simple and they can fix it? It doesn't impact their work, or is it something that has causing them to repeat the task, or it can be something that causes harm to the patient? So in these environments, what you can't quite see here, but maybe in the images, it's really crowded. There's lots of people. There's a tiny baby or a person in a bed, and they are connected with lots of tubes and wires. And any kind of changes or movements or bumps can result in tubes being pulled out and having a negative impact on the patient's health. So now this is a scenario where an X-ray is being brought into the room. Suddenly you have all of the stuff and then you're bringing in more. This is the second scenario. Now, the standard scenario has relatively few problems. And then when you get into the more complicated scenario, you see there are so many different instruments and people brought into the room. So suddenly you see there's more disruptions happening. You are getting the X-ray into the room, figuring out the patient needs intubation, uh, and at this point they're having to shift the bed. And now this is where the space becomes really interesting. And the reason why they have to shift the bed is because the room is not wide enough. So there needs to be people who are standing at the head of the patient's bed. There have to be the respiratory therapist on one side of the bed, the nurses on the other side, and that's not possible in the previous configuration because there's just not enough space here, because you've had to bring in a new bed. You have to replace the crib by a larger bed, and that's a whole other thing that happens over there. Um, and so suddenly this room is not working the way it should, and so you've had to move everybody. So the respiratory therapist, if you can see, is moving from all the way to the side of the patient to the bottom, to the other side of the patient. So everything, including the equipment, the wires, the tubes, everything is moving. And now in this surgery, in this particular situation where they have ECMO cannulation, it gets even more complicated because it becomes like a surgical procedure where you're bringing in tables with all the instruments that are required. We're bringing in surgeons. So maybe a couple of surgeons will be there. There'll be 2 or 3 respiratory therapists, 3 nurses. So it becomes extremely complicated in that space. The patient's family member at this point will not be in the room because there's no space for them. They have to be outside somewhere, and there'll probably be more equipment in the hallway because there's not enough space in the room. So you can imagine that in such a situation, it becomes extremely complex. And again, there's other complications with bathroom doors opening, conflicts along the path of movement, and it's hard to understand these things unless you study them sort of sequentially over a period of time. Uh, there are a lot of complications that can happen. So again, you're bringing in the X-ray, the ultrasound, and the surgical table has to be moved out of this room. So I think what this study has been really fascinating for us. It's a little study where we're just breaking up and seeing these interactions over a period of time. And what we've realized that it's not only complex in that particular environment, there are other complexities that we hadn't even anticipated when we started looking at this, because these rooms are actually mirrored rooms. That means uh, 2 patient rooms are side by side. They both have bathrooms on together, and if you enter the room, the bed is on one side, facing the left on one side and right on the other side. Uh, on the face of it, that looks like it should be fine, but there are significant complications in terms of where certain people can be. They have to be on the right side of the patient. So if they're on the right side of the patient in one room, that'll end up being the left side on the other side. And that can cause a lot of significant problems. You'll have to reconfigure the whole room. Everything shifts. So these 2 examples are meant to kind of share again how complicated these healthcare environments are and how we study them over the course of time to understand how humans interact with the space and time. Uh, and understanding this complicated sort of relationship is important for us to know what aspects of designs are going to work and what is not, so that we can design a space that is sort of has a longer life and it can have a longer impact. Um, so, in conclusion, humans are at the center of this dynamic system, and they're constantly adapting themselves and their environment over time to provide care. So, when we talk to healthcare providers, architects, clinicians, nurses, they just assume that the space is a given, that they have to kind of figure out how to make it work. They work in the most stressful environments where, there's not enough space to put down their materials. They kind of change things around and kind of squeeze through places, and in the most uncomfortable postures, just to provide the care that they need to provide. Their priority is providing patient care, but sometimes the space doesn't really support that. And what we found is that when the system has demands significant physical and cognitive adaptation from humans, if you have to rethink every single time how you work in that space, stress and burnout increases, and the chances for error increase. So protecting our staff by designing better spaces is super critical in order to prevent patient errors, errors for patients. In a well-designed and therapeutic environment should be intuitive, it should be flexible, and it should support all users at all times. And that should be the goal, I think, for all architecture projects. It should Even though it has that stability and it is fixed in time, it should still be flexible, and it should be dynamic, especially in healthcare, because the needs change so quickly every single day. Uh, and that brings me to the end of my presentation, and I'd be happy to take any questions.
Thank you, Dr. Joseph, so much for that fascinating talk. That was really, really eye-opening, and it's really just incredible what goes into the planning of ORs and hospitals design in general. Everyone, I'm Wilson Boehm, engagement specialist here at the museum, and I have some questions here for Dr. Joseph. The first one is from Catherine, and the question is: can you talk about your lovely use of the word choreography in this example of people using spaces?
Absolutely. The way I see it is that architecture, as I've mentioned, is sort of a fixed object. You build the walls, you build the spaces, and then you assume that life will take place. It's just a background or a setting for the drama that is life. And in healthcare, that's played out every single day in so many ways, sometimes heartbreaking, sometimes uplifting. But it is rarely neutral. It is rarely a backdrop. The architecture actually choreographs it without us even knowing. In many ways, the space kind of prompts us and directs us to move in certain ways and do certain things. Like in the PICU example that I just shared with you, because that room is designed in a certain way, it has a certain dimension, the width and the length. It just makes it happen that it's not possible to do certain kind of procedures in that room, so they have to move the bed, and suddenly there's a whole drama with moving wires, moving people, getting things to work somehow because of that space. And that's kind of I think, not the best example or the positive example of how architecture can choreograph behavior and people's lives in some ways. But there are so many beautiful examples too, where you're intuitively drawn to a room which has sunlight, which has a view of nature. You function better in a classroom that has daylight, where you're fresh air, you're more awake, you're more alert. So architecture is every single moment that wherever you are, you live in a space, and that is, whether you're aware of it or not, it is kind of choreographing the drama that is life. I guess that's where the title comes from.
Great, thank you. And actually, Catherine had a second question, and is having a window in an operating room to see outside feels like such a radical change. Are there any concerns or only benefits to that?
It's interesting. I mean, I think there's a lot of organizational and cultural factors associated with why we don't have enough operating rooms with windows here. If we go back to the early part of this century, most of the operating rooms had large windows because it was so important for them to have enough daylight to be able to see what is going on with the patient and to do the surgery. They even had windows that were operable so that you could have fresh air. And then hospitals kind of evolved over time, where windows were always shut and closed, and the air was artificial. I mean, you had air conditioning, you had ventilation in these buildings. And then eventually it came to a point where often operating rooms were in the basements, because they felt you could have artificial light. You had the surgical lights that would give you the light you needed to work on the patient. And then as the operating room procedures evolved, then there was a concern that when you get to laparoscopic surgeries, where you have to view the patient, the surgical site on a screen, there may be issues with sort of glare and other kind of elements that may impact the surgery. So there may be various factors that are impacting why you don't have windows. But if you look at operating rooms designed in Europe, most of them have windows. In fact, windows are required in all spaces where people work for a certain number of hours. So there's no reason why they cannot be incorporated. I think it's important that when you have those windows, there should be a way to control the daylight. If you have glare, that can impact the visibility of screens and displays. So being able to control the daylight for privacy, for glare issues, that's important. But you should be able to open those windows, or not, open the windows, but so at least be able to look out of the windows between surgeries. And there's quite a significant amount of time between when the intraoperative phase, you probably want the windows closed, but there are enough times before and after that you could have the windows open. It would probably be a more humane environment even for the patient as they were entering into the space. In fact, this particular image that you see in front of you, this was a rendering that one of the students created of their vision of as a patient. If you were entering into the OR, this is what you would see. So you would kind of have this display wall. It would be a intelligent kind of a wall where you could display a view of nature or something therapeutic. And once the patient was induced and unconscious, you could use the same wall to display the patient vitals or a view of the surgical site or some other information that the whole team needed. So that's the kind of innovation we need. Maybe if it's not even a window, but it's an artificial view or something that's more calming, uh, it would make a difference.
Yeah, I would say so. Especially as you enter the surgery room, the operating room. I imagine that would make me feel a little better.
Yes.
Um, one more question here. Is there a common misconception or that you've encountered about the design of healthcare environments?
When you say common misconception
Are there any common misconceptions that you've encountered around the design of healthcare environments? I know I just repeated it.
I mean, I think from my perspective, but just misconceptions in terms of also how interesting and exciting it is. So I think as an architecture student, when I did my 5 years of architecture in India, I didn't know a thing existed. The healthcare architecture was a thing, and that designing hospitals could be interesting. I didn't even know such a thing existed. And then when I did my master's, I learned about this field of environment and behavior and how design can impact different health outcomes. And that just got me more excited to learn more about it. And as I have spent time in this field, I think it's absolutely fascinating to know that through design, you can make a difference. You can really um, be sort of an activist in your own way. You can kind of look out for the patient, for the staff member, and you can create an environment where you would want to be treated as a patient. So it's a really exciting and sort of space to work in. It's intellectually very challenging. It needs a lot of critical thinking to kind of balance all these different priorities. Um, and also you end up working with the most fascinating people. I found that in many of the design projects we worked on, the clinicians that we work with, the architects that we work with, they all have this common sense of mission, that what we're doing is to improve patients' lives, to improve people's lives. And it just makes that, there's hardly, I could say, ever a person I've encountered who's not humble, because they know this problem is so much bigger than themselves, and that architecture is meant to serve. So it has this whole sort of passion behind it. And I think there may be others out there who think it's not sexy enough. It's not, in that sense, maybe misconception. But other misconceptions could be that these are sterile spaces. Some of them are. I'm not sure what other. I mean, I'd love for the person who submitted their comment to see what are some of their misconceptions, and maybe then I can help to allay some of those or respond to that in some way.
Yeah, let's see if they comment here in a second. I actually had a question about around kind of climate change and extreme weather, and if there's some like a design element, or if that's a factor when it comes to design of a healthcare facility.
Absolutely. I mean, I think that's any kind of architect, any architect who's building any buildings these days has to be aware of
Sure.
the big issues, because healthcare facilities are one of the largest consumers of energy. It's very hard to make them energy efficient because there are certain concerns that you can accommodate in office buildings or other building types, but healthcare facilities just require a lot. They have to be kept open 24/7. They huge consumers of electricity and water and other resources. So there's a great push to try and make them more sustainable, and that's often kind of bringing in green spaces, kind of creating green roofs, sustainable materials to the extent possible, energy efficient methodologies and ways to save on energy costs. So there is a big push for those kind of things. They're trying to make healthcare facilities as sustainable as possible in terms of the impact, the carbon footprint that they have. Um, but sometimes it's a challenge because some of the strategies that you can implement in, say, a residential building or an office building are not feasible in healthcare facilities because there are issues with infection control and protecting the patient from harm. That becomes sort of the overriding concern. And anything that may, for example, say if you could use gray water uh, for flushing or for in other kinds of buildings, those may not be feasible in patient rooms because of risk of infection control. So there are those kind of elements, but healthcare architects are just as aware and trying to respond to these kind of elements as well. And then changes with resilience and for example, in California, hospitals have to be designed to meet the codes regarding earthquakes. In places like Charleston or in New Orleans, hospitals have to be designed very much in keeping with issues with rising water levels and protecting for all kinds of sort of emergency situations that may happen. So yeah, those are real challenges that we have to address.
Great, thank you. And do you see any changes happening with people's approach since COVID began, or if that affects design or just the way they think about it?
Yeah, absolutely. I mean, infection control and focusing on healthcare-acquired infections has been a challenge forever. And that's been one of sort of the basic problems that we've had ever since the Institute of Medicine report came out in 2000. It showed that there are, I forget how many, 100,000 infections in the US on an annual basis. People die from healthcare-acquired infections, from errors. And that is a huge focus of the efforts that architects are working on, healthcare systems are working on, because I'm not sure how much this audience knows that the number of people, healthcare-acquired infection is an infection that you acquire because of the healthcare setting. So this is not something that you go into the hospital with, but something that you might acquire because of being in that space. And often the infection is from materials around in your environment or from the air that you breathe, and design can impact that. So this is always a concern, especially in ICUs and operating rooms and emergency departments. With COVID, it has become even more challenging because you suddenly had this huge need to provide intensive care unit rooms, and many, often more than many hospitals have. So they've had to retrofit other kinds of spaces like operating rooms or recovery rooms to intensive care unit rooms. And in that case, then you have to make sure that the ventilation is appropriate for those patients. They've had to think about patient flow in throughout the hospital. Where do people flow clean and dirty and infected and non-infected, and how do you separate out spaces? So it's been a huge challenge for my field, for healthcare architects and healthcare systems, on how to provide the essential care in an unexpected situation that COVID-19 is. But at the same time, many of the procedures that they would do normally, like elective procedures and surgeries that you may want to go for otherwise, the doctors are kind of keeping the patients out because they don't want to risk infection for those patients. But those are also how do you kind of accommodate all these different kinds of requirements in that space becomes the challenge. I have a couple of slides about infection control. I just added them in. If there is time, I can present that, or if you have questions, we can.
Yeah, that was the last question. So if you want to share that to finish up, that would be fine.
Okay, great. So I just put in a few slides because I thought some people in the audience might be interested in sort of what our field is doing in terms of infections, and these are the pathways, and everyone is well aware and is almost an infection control expert themselves with everything that's been going on with COVID. There are multiple ways in which infections spread in the hospital, much the same as they spread in your home or in your school or wherever. It can be airborne, waterborne, or through contact transmission. In fact, in healthcare facilities, a lot of the infections spread through contact, where a nurse may interact with a patient and then they touch something and then somebody else touches that, and then that's how infections spread. This is kind of a funny, but actually not very funny, but fairly true little cartoon. It says the patient in the next bed is highly infectious. Thank God for these curtains. And what we found through our research is that multiple bed rooms where there are multiple patients, they pose a significant risk to the spread of infections. As you can imagine, just by people coughing or contact infections, that curtain is usually the reservoir for all sorts of germs. And the same people, multiple people will touch it, and they'll touch different patients, and that's how infections spread. And the research has shown that single patient rooms make a big difference because they reduce the chance for airborne infection. It makes it easier to clean a patient room after a patient leaves. Suppose a patient is infected. If there are two patients in the room, you cannot possibly clean it out and disinfect it the way you'd want it to be. And it's important, it's easier to maintain air quality as well. One other thing we found was that when there are multiple patients in the room, it's hard for clinicians or the healthcare workers to clean their hands because they get distracted. Just think about it now. You've probably become obsessive about washing your hands and singing happy birthday and all of that. But how long that takes and how many times a nurse is interacting with multiple patients. And if you have, say, 3 patients in the room or even 2 patients in the room, the nurse is going quickly between one patient and the other, and they may forget to wash their hands. And so this hand washing compliance, that's the biggest thing. That sort of the way to reduce infections in hospitals is just hand washing. And the compliance is really low for many of the reasons, as we ourselves know how hard it is to remember to wash your hands after you touch anything. So this was an interesting design response by one of the facilities that I worked with, where this is Dublin Methodist in Dublin, Ohio. So they built this patient room where they said, we're going to make hand washing a really big deal. We are going to celebrate hand washing. So as soon as you enter the room, you see this blue line in the floor that leads your eye right to the sink, and there's a spotlight on the sink, and there's a blue glass wall behind the sink. How pretty this is. It's beautiful, but it's also very well designed. The whole idea is to make it easy for the clinician to find their way to the hand washing sink so that they're not distracted. And this is a single patient room as well. And what they found was after they implemented these hand hygiene stations is the hand washing increased significantly, and there were no documented infections, UTIs, after this for a while at least. I haven't gone back and looked at the data since, but they were very effective. Just a simple design solution. And this is the converse of that, right? This is what often happens, that you enter, the sink is behind the door, and it's out of sight, out of mind, and you forget to wash your hands. So that's hand washing sinks, alcohol rub dispensers have to be located on the path of movement in order for people to wash their hands frequently. And I think that's kind of my little spiel on not so much COVID, but infections and the spread of infections in hospitals. There's a lot more with air quality and ventilation and all of those things. But I just thought I'd share a few thoughts with you, and look forward to hearing your comments.
Well, thank you so much. It's nice to know that we have passionate and smart people thinking about these things for us, so that when we go to the hospital, we can be safe and we don't have to worry about these things. So thank you so much, Dr. Joseph. And we are all out of time, but we really do appreciate you joining us for ArtBreak, and we look forward to the next one, I think. So thank you everyone for joining us. Have a wonderful night.
Thank you.